Thanks, Brian. You can see that's recording. Okay, so I'm going to talk to you about lung ultrasound today. The talk will be about less than half an hour. Um, you may start to ask, why would we want to do lung ultrasound? It seems like we're getting less resources all the time. That there's, there's less nursing staff, there's less space in the department, and there's less time. Um, don't forget about the endless paperwork and filling in your electronic health record as well. And it seems like you're doing a lot more with a lot less. And I think, it is time to break the mold, and I think you need to disrupt the status quo. I think you need to step out of the box. And I think with lung ultrasound, you can certainly do that. And I'm going to show you how this happens in the next few minutes in the presentation. Okay, so lung ultrasound started with these two gentlemen. Okay, I think we need to mute someone there. Lung ultrasound started with sorry guys, can I ask all people to mute their microphones if that's okay, please? Thank you. Oh yes, okay. So lung ultrasound started with these two gentlemen here. So the man on the left here is Daniel Lichtenstein. So Daniel Lichtenstein is a French intensivist, and he started writing a lot about point-of-care ultrasound, or lung ultrasound in particular, in the late 90s. He published a few papers describing lung ultrasound artifacts, which he really extrapolated from the animal studies, in particularly horse veterinary medicine. He came up with the Blue Protocol, which is what we base a lot of our lung ultrasound examinations on at the moment. The man on the right is an Italian gentleman by the name of Giovanni Valpicelli. So ever since Daniel Lichtenstein published all this material, Giovanni has published even more, studying the effects and how good it is at the bedside. And between these two gentlemen, there's a whole wealth of literature about lung ultrasound. So this is the Blue Protocol that Daniel Lichtenstein described. It looks a little bit, looks like there are a lot of arms there, but in actual fact, as long as you can categorize a patient into an A, B, or C profile, and you work through the algorithm, you can get to your diagnosis pretty reasonably. Now, there are a few caveats with this study, in that it was a single provider, and that was Daniel Lichtenstein, who is an expert in lung ultrasound. Basically, it was done on patients who had one and only one pulmonary pathology. Lung ultrasound is all about artifacts. Unlike cardiac echocardiography, where over here you can quite clearly see what is the left ventricle, the left atrium, right ventricle, and right atrium. Lung ultrasound is basically this. So all you'll see is the pleural line, the VPPI, as I'm pointing out here. And then anything below that is really all just artifact. And lung ultrasound is really the interpretation of this artifact and how it fits in with the clinical situation. So talking about artifacts, so there are two general artifacts that we talk about in lung ultrasound. The first one is the A lines. So A lines, all these artifacts are all reverberation artifacts. So the A lines are formed when the ultrasound beam hits the pleural line. It gets reflected to the ultrasound transducer, and it forms this single line. But the ultrasound will keep bouncing between the transducer and the pleural line, and it will form subsequent parallel lines, and these are called A lines. So A lines only really form when you are insunating the pleural surface at a right angle. So if you tilt or you rock the probe, you may not be able to see this if you're not insunating at a right angle. The other artifact is the B lines. So B lines are formed, again, ultrasound beam hits the pleural line, goes back, it forms a single beam. But because the surface architecture of the pleura, the alveolus, it's postulated that as there's more and more fluid, or the lung parenchyma is more and more dense, these reflections happen many, many times, and they go all the way down to the far field. So that's the reverberation artifact. So what are your differentials? So if you see A line, so oftentimes trainees and other colleagues, they tell me A lines is normal, it's normal lung. So that's not necessarily the case. A lines are air-filled spaces. So any of these pathologies are air-filled spaces, and you really have to put this into your clinical context. Differential for B line, again, depending on whether they are unilateral or bilateral, these are your various differential diagnoses for them. Again, clinical context is very important. B lines are essentially a densitometer. So as the lung gets more and more dense, be it by consolidation, interstitial fluid, a pneumonia, for example, there are going to be more and more of them, and they're going to be more and more confluent. As you can see here, these studies, this is a pretty old study, this is from 15 years ago, and it shows a pretty reasonable correlation between lung ultrasound B lines and, in this instance, extravascular lung water. So the more B lines you have, the higher the amount of extravascular lung water. And over here, your pulmonary capillary wedge pressure, you can see it increases as B lines become more and more. Now, how come I can't go forward? Okay, excuse me now. So, okay, so at the end of the day, you take it that A lines are horizontal and B lines are vertical. So lines that are horizontal to the and parallel to the pleural surface, they are A lines. B lines are the ones that go from the pleural surface all the way into the far field on the ultrasound. So which probes can you use? You can use any probe. So just to repeat, you can use any probe, but preferentially you would use a curvilinear probe to interrogate the lung. So you can see pathology at the pleural surface. You can also see pathology further afield, or maybe slightly deeper, for example, like pleural effusions or pneumonias. So how are you going to do this? So as with any clinical examination, you need to be quite systematic. So they have described dividing the lung zones into 6 or into 8 zones. I personally prefer 8 zones, and most of the literature is based on dividing the lung into 8 zones. So the medial borders are the parasternal line. The middle line is the anterior axillary line, and then there's a posterior axillary line. And then there's a line that intersects the nipple, and that produces 4 zones on each side. And you would insonate as you would use your stethoscope, bilaterally comparing the same zone with the same zone. Now, if your patient is supine and you want to scan the posterior lateral zones, so you need to adopt a fast view, so an E-fast view in your left upper quadrant or right upper quadrant, and you need to slide up to look for the diaphragm. So the diaphragm splits the abdominal, obviously the abdominal cavity from the pleural, the thoracic cavity, and therefore you are able to delineate what's intra-abdominal and what's intrathoracic pathology. Don't forget that a lot of your pleural surface, a lot of your lung is actually posterior. So if your patient is ambulatory, remember to either sit them up or lie them on the sides and insonate the posterior zones as well. Now, initially start with a longitudinal scan. So use the probe marker facing towards the patient's head. You can rock the probe to look for areas that you're interested in. If you want to be quite more specific, you can then rotate the probe 90 degrees and scan in between the lung zones. But make sure you actually scan as many zones as you possibly can. So Daniel Lichtenstein has described his blue protocol, but I think for most practitioners of lung ultrasound, they prefer to divide where you scan or how you scan into the anterior and posterior zones. So We'll divide this first. So in terms of the anterior zone, we're talking about pneumothorax and interstitial syndromes like acute decompensated heart failure or fluid overload. So we'll talk about pneumothorax first. So pneumothorax is one of the easiest ways of using lung ultrasound to start. So how does this go statistically? No lung sliding and lack of comet tails. Your positive likelihood ratio is 50.5 and your negative likelihood ratio is 0.09. So what does that mean? So I think as a clinician, you're more interested in the likelihood ratios. Whenever you look at a RCT or a paper, you should really interrogate it for likelihood ratios. So this is a Fagan nomogram. Everybody is actually doing this. So if you're not a statistician, you are doing this every single day of your clinical lives. You assess a patient and you come up with a pretest probability. Okay, so your pretest probability can go from anywhere from about 0 to about 100%. And most of the times you range anywhere between 50 to about 75, as good as you can get about how sure a patient how sure you are of a patient having a pathology. Clinical gestalt only gets you to about 75%. You apply a test then, which has a likelihood ratio anywhere from 0.001 to 1,000. The main part to note is that 10 is a rule-in and 0.1 is a rule-out. When you join the dots, you get to a post-test probability, okay, and that tells you what is the likelihood of your patient having a particular pathology after you have performed the test. So let's apply the lung ultrasound with pneumothorax, okay? So we say we are 50% sure this patient has a pneumothorax. If we perform this and we don't see lung sliding, okay, and we have no pleural line artifacts, you can more or less rule in the pathology. If you apply it, you can also use it to rule out a pneumothorax at that particular zone, and it's the almost ideal test for a pneumothorax. So how do you scan? Again, be systematic. Scan anterior. If your patient is supine, if your patient is sitting up, you may want to go a little bit more towards the apex. Now, what do you actually see? So when you actually interrogate the pleural line, so this patient does not have a pneumothorax, you can see the lung sliding. So you can see these little, the pleural line, there seems to be like what people describe as ants marching across the screen. There's a small little comet tail artifact here. So in this case, no pneumothorax. Over here, you see this oscillation. So it's unlike the sliding that you saw in the previous clip. So you see this kind of back and forth oscillation. This is what we call a lung pulse. So a lung pulse means that there is no pneumothorax, but the lung is actually not ventilating very well. Now, you can also use M mode to decide whether there is a pneumothorax or not. So the seashore sign means that there's no pneumothorax. The barcode stratosphere sign means that there's no motion detected on the M mode, and that's your that's highly suggestive of a pneumothorax there. So over here, on the left, you can see pleural sliding. Okay, some pleural line artifacts here as well. Over here, besides the respiratory muscle movement, this is the pleural line. You do not see any movement there. So there's no back and forth or no sliding kind of movement here. So this is a pneumothorax. Over here, you see the lung point. So a lung point is where there is pleural sliding on one side of the pleural line, and then after that, there is no pleural sliding over here. So this is where the visceral parietal pleura actually separates. This lung point is actually where the visceral and parietal pleura separate. So where the lung is becoming coming away from the chest wall, as in a pneumothorax. This is the point where that is happening. This has been described with 100% specificity for pneumothoraces or the diagnosis of pneumothorax. Next, we'll talk about interstitial syndrome. So this is fluid overload, acute decompensated heart failure, and ARDS. So okay, so greater than 3 B lines in 2 bilateral lung zones. Okay, so that's your positive likelihood ratio of 12.38. and negative likelihood ratio 0.06. Again, positive likelihood ratio more than 10, you can rule in. Negative likelihood ratio less than 0.1, you can rule out. How does this, when you compare this with symptomatology, so for example, orthopnea, the presence of orthopnea or the absence of a cough in symptomatology. So there was this large meta-analysis that was actually done by Abel Wakai, who is one of the emergency consultants in Martindale, and Abel actually wrote this paper back in 2015. And there's a lot of information about the test characteristics of a lot of the symptomatology, the radiological investigations, your clinical history, even about the likelihood ratios of diagnosing acute decompensated heart failure. So with orthopnea, the positive likelihood ratio is only 1.9, and that's the highest positive likelihood ratio from symptoms. Your absence of a cough is 0.6, and that's the best negative likelihood ratio you can get. You feed this in, you see that it doesn't really help you. If you're kind of unsure whether this patient has acute decompensated heart failure or not, the presence of either of these symptoms is not really enough to either rule in or rule out the diagnosis. When I was in medical school, most of the professors, the medical professors, they told us, listen, if you've got wheeze, that's obstructive obstructive pathology going on in the lungs, and if there are rales, it's likely acute decompensated heart failure. How does that perform? As you can see, not very well. When you feed it in, it doesn't really help with your post-test probability of whether a patient has or has not decompensated heart failure. Next thing, we come on to biomarkers. So biomarkers like BNP, NT-proBNP. So there's actually two different types of biomarkers. These biomarkers are good if they are low, as in less than 100 or less than 300, depending on your assay. It's a good rule-out test. Unfortunately, if it's positive, it doesn't really mean a whole lot, to be honest with you, because this test, it can be high for many reasons. So if you have tachycardia, if you have atrial fibrillation, the patient is septic, if they have heart failure with a preserved ejection fraction, all their BNPs can be high. And it does not necessarily tell you that someone with a high BNP is definitely acute decompensated heart failure. The other thing as well is it has spectrum bias. So spectrum bias is where if someone has if you're absolutely sure that this patient has acute decompensated heart failure, you do a BNP and it comes back high, that's great. However, this test does not perform very well when you're unsure. So if you're unsure whether the patient has BNP, has a decompensated heart failure or fluid overload, you do this test, it's going to lead you into a world of trouble because it's going to lead you down the wrong path. So again, as you can see, yes, it's an excellent rule out, but I wouldn't use it to rule in decompensated heart failure at all. Now, this is the mainstay of our diagnosis, I suppose, in the intensive care unit about whether someone's overloaded or not. And it actually performs quite well. So as you can see, likelihood ratio 6.5, and the absence of cardiomegaly gives you a negative likelihood ratio of 0.43. So that is, that of all the tests that we have so far, that is one of the better ones. But if you compare that with lung ultrasound, as you remember, it's more than 10, and you can definitely rule it out. That's pretty good. So what does lung ultrasound look like? So B lines, as the pathology gets worse, it becomes more and more confluent. Okay, so this is, again, more B lines. This is what it looks like. All right, this is when it's getting worse and worse and worse. And this is using different probes. So this is using a phased array probe, a cardiac probe. So you can use any probe really to do lung ultrasound. Now we talk a little bit more now about posterior pathology of the lung. So pleural effusions and pneumonia. So pleural effusions, if you get a chest X-ray like this, what is in that white area? Are you going to stick a drain in? Maybe not. Maybe. We're not too sure. You can get a CT, but if the patient is very unwell and needs a drain pretty quickly, bringing the patient down for CT may not necessarily be the easiest thing to do. The transfer will certainly be very hairy. So how does lung ultrasound perform? So if you have anechoic fluid above the diaphragm, positive likelihood ratio of 47, negative likelihood ratio of 0.06. Again, good enough to rule in, good enough to rule out. Feed it into our so-so patient. We are not too sure what's going on with this patient, whether he has or has not. Okay, again, you can see you can rule in and can rule out with this test alone. Remember to scan posteriorly if you can. And again, if your patient is supine, make sure you interrogate the areas around the diaphragm very specifically. Again, coming back to this, start longitudinal, and once you find an area that interests you or where you think the pleural effusion is pretty big, or you want to measure the volume in the pleural effusion, you can rotate the probe 90 degrees and try and get between the ribs. So this is what a normal lung looks like. So this is what we call a lung curtain. So this is the liver. Kidney is over here. Diaphragm is that white line that you see over here, and that's actually lung. So lung, air does not, lung ultrasound does not pass through air. And this is what we call the lung curtain. Okay. Now, if we look at this here, you can see that this is the vertebral spine. Okay, this is in orange. The diaphragm is in red. The pleural line is blue, and you can see the A lines are all green. Okay, so as you can see, it's going across. No pleural effusion on the previous slide. Here, you can see that's quite different. So this is your diaphragm. This is your spine. You can see the spine is actually going above the diaphragm. All right, and there's this anechoic space here. There's a bit of lung that kind of pops in every now and again here. So this is a pleural effusion, okay? And this is what we call the spine sign. So if the spine goes above the diaphragm, so if this is the spine, okay, this is the pleural effusion right here. This is your liver, this is intra-abdominal, and this is your the spine going above the diaphragm. Okay, this is your costophrenic angle. Okay, now so let's move on here. So now we're going to look at this one here. So now again, small pleural effusion here. Okay, this is a lung that looks quite consolidated. This is a left upper quadrant scan, so you can see the diaphragm is over here. So small pleural effusion, probably not worth trying to stick a needle into this. Now, this is getting bigger. Okay, so you see there's lung tissue here that's all compressed down. This is what we call compressive atelectasis. Could be a pneumonia in there, but I'd be a little bit more cautious about calling that a pneumonia when you have a very large pleural effusion present. This goes back to your clinical context, so you need to see if the patient is obviously tachycardic, shock, pyrexial. Then you consider this maybe a parapneumonic effusion. Alternatively, this could be fluid overload either, and it's just a simple pleural effusion from that, causing compressive atelectasis. Now, this is a much larger pleural effusion, so you see all the lung is all just squashed down. This is huge amount of compressive atelectasis. This is what we call a jellyfish sign. It looks like a little jellyfish swimming around in the pleural space. The diaphragm is here. Okay, this anterior chest wall, and this is the spine. Okay, so this is another large pleural effusion. This is a malignant pleural effusion. And this is a pleural effusion on the left side. So you can see that the heart is actually delineated here. And then as you go more superiorly, so this is sliding the probe up superiorly, you can see that there's quite a few B lines and quite a lot of pleural irregularities. So this is actually a parapneumonic effusion. Patient was pyrexial, slightly shocked, needed some antibiotics and needed drain. So now the other thing as well that lung ultrasound is useful for in pleural effusions is actually deciding on whether the effusion is complex or not. So you can see here there's a lot of fibrin stranding. There is a pleural effusion here. The diaphragm is here. And if you stick a drain into this, you may not get very much out of it. Okay, and this is a simple matter of actually just putting the ultrasound probe on the patient. You don't need to bring the patient down to CT to make that kind of a decision. Now, this is an even worse pleural effusion. Okay, so this is a TB pleural effusion. There's lots and lots of fibrin stranding. If you stick a drain into any of these pockets, all you're going to get is a few mils, and then the rest of it is all trapped in this area. So this guy needs a VATS decortication or a bit of TPA down the chest drain. Okay, so pleural fusion on a chest X-ray. When you do a supine chest X-ray, you need at least 500 mils. Ideally, they should be lateral. It should be a lateral film and as upright as possible. Now, most of our patients in the intensive care unit are supine, so you need a fairly large pleural fusion to show up on a chest X-ray. With ultrasound, you just need 20 mils and you don't need any special maneuvers. Draining a pleural fusion can also be guided by ultrasound. So you can do it statically, as in you mark the pleural space. I don't really do it static. So I would usually tend to use a dynamic process where I actually watch the needle going into the pleural fusion. And there's literature out there to suggest that doing pleural taps without ultrasound is actually a lot more dangerous. So you can see there's a 10 times risk reduction, relative risk reduction using ultrasound to drain a pleural fusion. Okay, so we talk very quickly about pneumonia. So again, hepatization, air bronchogram stride sign. Okay, so pretty good performer again, as you can see. Negative likelihood ratio also enough almost to rule out. Now this exam is a little bit more. You need to scan a lot of lung territory here. I wouldn't just base this just on a single zone scan. So you need to scan a lot of zones. So it's a little bit more time consuming. So what does it look like? So this is a left upper quadrant scan. So this is the diaphragm. This is the spleen. This is the diaphragm. Small pleural fusion over here. You can see this is the pleural line here, and it's very, very irregular. So pleural fusion, consolidated lung here on this point here. Okay, so over here, some pneumonias are cavitating, form cavitating lesions. So this is a cavitating lesion here. You can see there's a big space here and just under the pleural line, and this is quite a nasty cavitating pneumonia here. This is what we call hepatization. So this is the liver. This is the diaphragm. Okay, you can see how the texture, the echo texture of the lung tissue looks almost exactly like the liver. So much so that you might think that all of this is liver. So this is a very, very heavily consolidated lung. You might see some air bronchograms in here. So see these white little lines here that come in and out of view as the patient inspires and expires. This again is another very heavily consolidated lung. You can see dynamic air bronchograms and static air bronchograms as well. Small pleural fusion. Again, the liver down here, looks exactly the same as the liver. So at this point, you might ask, what are you going to do? Are you suggesting that I just put away my stethoscope and just do lung ultrasound? So I'm not suggesting that. So there have been a few studies about this actual process. So this was a study done by Pivetta's group in Italy, where they took 520 patients. They did a clinical evaluation on all the patients, and they came up with so these were all dyspneic patients. So basically, they came up with either a diagnosis of decompensated heart failure or non-acute decompensated heart failure. After that, they randomized the groups into either getting a lung ultrasound or a chest X-ray and pro-BNP. So let's have a look at these results here. So with the clinical evaluation here, so you can see here 7.2. So in these groups, the clinical evaluation was actually pretty good. But in this one, where they used or they just added on a chest X-ray and NT-proBNP, the likelihood ratio did not change very much at all. However, if you look at just the group where they use clinical evaluation and lung ultrasound, you can see that the positive likelihood ratio jumped by quite a bit. So this tells me that you actually can cement your diagnosis with lung ultrasound alone. There have been other studies as well, and all of these studies point towards incorporating lung ultrasound into your diagnostic toolkit, as opposed to just using lung ultrasound alone. So just talk scenarios here, okay? So now, I think most people of this group would have known about, would probably know about a patient like this, or can think back to a patient like this. a 69-year-old and has just been intubated for respiratory failure. We put in a central line, and we are in full PPE. It's sweaty, it's hot, it's noisy, and then the patient becomes hypoxic and drops their blood pressure. So there's quite a couple of things there that go through your mind. The dope's pneumonic. You want to make sure that they don't have a pneumothorax. But remember, you've ordered the chest X-ray already, but because of what's been going on, and I'm trying to stay away from the COVID word. They say that they are about 30 minutes away because they're doing lots and lots of other chest X-rays. So you try and listen. It's difficult to listen in all the PPE. The patient wasn't ventilating very well before they got intubated, so it's difficult to see chest rise before. It's now even more difficult to see whether there's any chest rise. But you do have an end-tidal CO2 reading. So because you've just put in your central line, so you still have the linear probe available. So you have a look at the lung surfaces. So anteriorly on the right lung field, you see the pleural sliding. So there's no pneumothorax on the right side. You look at the left lung field and you see this. So you see this kind of oscillation. So remember we said there was no pneumothorax with this, but there's a possibility that we not be ventilating this lung very well. Let's take out the curvilinear probe and let's have a look at the diaphragm. So have a look at the diaphragm here. So you can see the diaphragm moves on inspiration, expiration. On the left side, this doesn't seem to move very well at all. Okay, so the diagnosis for this. All right, right main stem. All right, right main stem intubation. So we pull back the ET tube just a little bit. Okay, and then you see here on the left side, the diaphragm starts to move again straight away. All right. So scenario 2. This is an ED case. A 90-year-old patient, recent discharge, was treated with a UTI, and then has now some slight life-started chest pain. Presents with fevers, rigors, hitting multiple SIRS markers there. Her urine is clean. And the SHO has come to me and says, I'm not too sure what's wrong with this lady, but, she seems unwell. So he shows me the chest X-ray. And the chest X-ray looks normal. We get a read from the radiologist that says it is normal. So that's day zeros. We take the ultrasound probe and we have a look at the left side of the chest. So you have a look over here. So stomach, spleen, diaphragm, consolidated lung, pleural fusion. Your diagnosis is done. Okay, so left-sided, lower respiratory tract infection. Start some antibiotics. Get her admitted. Okay, this is what it should look like. This is what it should look like. It should be normal. Okay, if it was normal, but it's not. And then day 2, the inpatient teams do a chest X-ray, and then only at this point do you start to see a small meniscus here, the formation of a pleural fusion. Okay, so very quick, very fast, sometimes faster than our standard modalities. Scenario 3. This is the typical ICU patient, 67-year-old lady. She's been an inpatient for 3 days, being treated for acute decompensated heart failure. We're trying to diurese her really hard, but as far as you can go, you're only getting an even balance each day. And her sodium is rising, her pH is going up, her bicarb is going up. She is tachycardic. She is on some NORAD. There are multiple points here where you say, hey, look, I think she's probably dry. We probably will stop diuresing her. But we have a look at her chest X-ray. So her chest X-ray still looks like she's got some infiltrates bilaterally. Looks like a left lower zone pneumonia. Again, no comment. So this was read as well as just a left lower zone consolidation. Right lower zone consolidation. No comment about the pulmonary vascular markings. No comment about pleural fusions. So we take out our trusty ultrasound and we put it on her chest. Lots and lots of B lines all over the place, suggesting increased extravascular lung water, suggesting an increased pulmonary capillary wedge pressure. This lady's still overloaded. You can incorporate lung ultrasound with other ultrasound modalities as well. So this is a lung. So she's got actually bilateral pleural effusions that are not seen on chest X-ray because you're supine. Okay, they aren't very large volume, but they are certainly significant. You look at her IVC and you can see that her IVC is quite dilated. There's no respiratory variation. It's 2.1 centimeters, suggesting that she suffers from an acute lack of diuretics. You look at her heart, her EF is slightly reduced. You might even suggest a wall motion abnormality at the apex as well as the septum. When you look at her valve, her mitral valve, it's a little bit leaky. She's got a bit of her LV filling pressures are a little bit raised as well. Now you can combine this if you go even further into this. So this is what we call VEXUS. Pulmonary congestion. How congested a patient is. It's usually a lot of downstream effects. This is something that I've been looking into quite recently, and it pairs very well with the lung ultrasound. Okay, so we put her on furosemide infusion. We give her 80 milligrams of furosemide start. We give her some acetazolamide for the contraction alkalosis, and we give her some metolazone to get rid of to allow her to have natriuresis instead of just diuresis. And she starts pouring out urine. Okay, so in conclusion, Jeff Klein, who is the famous, who has published multiple papers on pulmonary embolus, and he's not really a big fan of lung ultrasound for the matter. He says that lung ultrasound is the kindergarten of point-of-care ultrasound applications. It is one of the simpler applications to learn because image acquisition is not a big thing. You really just have to interpret your artifacts in your clinical context. An integrated approach is best. Again, as we're saying, don't just use it alone. Combine it with your clinical acumen. And as you can see so far from the presentation, that it is the best bedside diagnostic modality for lung pathology. And that's it. Thank you so much. Let's see if there are any questions that have come up so far. Brian?
Sorry, my mic was on mute.
Oh, no worries. Yeah.
So no questions to the chat so far, but I might just kick off with one. So do you think we should be replacing kind of routine chest radiography in our intensive care units with increased use of point of care ultrasound and lung ultrasound?
Okay, so Alan Gaffney, Dr. Gaffney, are you around?
I am. Hi, Nick.
Hi, I was wondering, what do you think about that, replacing a chest X-ray with lung ultrasound?
So I suppose the one thing that I would say about ultrasound is, and especially point of care ultrasound, that when you do it yourself and you see the images in front of you and you make a change based on it, you can be confident that the change you made was based on those actual images in front of you. However, the next day, and you're talking to your colleagues, you're talking to anybody else, there's rarely a record kept of them. And the beauty of chest X-ray is that you can look back day after day after day, and it's there on your system, and you can compare. So you don't have to be the person that takes the chest X-ray, but you can be the person that compares them over time. So I think until we got to a point where you had a standardized way that everybody would record ultrasound, and that ultrasound was available to compare over time, I think a bit like doing even echo at the bedside, it's what I tend to do is when I do my own echo, I also get a departmental echo, because with a departmental echo, you have that both a report and the recorded images available afterwards. So I think until we get that side of things, which is a technological issue, it'd be hard for me to see that we could replace them initially. But I know there are some units that are very big into lung ultrasound that feel that the information that they can get is just as good or better than chest X-rays. But again, I think the recording of them is crucial.
I would tend to agree with you there as well, because it's sometimes difficult to actually go back and pass through, if someone has actually made a clinical decision, what they actually made their clinical decision based on. especially if, say, for example, it's something life-changing like pneumothorax or something like that, like someone said they did not see lung sliding, but, we cannot see the images, then, it's quite difficult to actually stand over that, I suppose. And I think, trying to get that onto an image storage solution would probably be the best way, for example, either PACS or the NIMS system, or even a departmental system where that images can be reviewed if and when clinical decisions are made on them. Does that answer your question, Brian?
Yeah, I think it does. And I think the follow on then from that is, how should we formally accredit people in lung ultrasound?
So I suppose there are various pathways out there. So at the moment, I think so I'm a physics mentor. So this is Intensive Care Society. They have the physics program, which is there's physics heart, and then there's physics lung as well. So you can actually do a module. You acquire a certain number of images. You make sure that you are actually mentored, and I think the quality analysis piece is very important, so that someone, if for example I'm the trainee and I get a good few images, I want to make sure that I show it to someone who is able to look at the images myself. So I've got another spicy question here from Thomas Villan. So Thomas Villan is one of my great friends from Spain. So he says in the chat, is there any accreditation for using the stethoscope? No, unfortunately not. I suppose when you get out of med school, you get you get a license to use the stethoscope. And you don't get any accreditation, I suppose, for that. What do you think about that, Peter?
Oh, I love it. So I think that's a great question. I guess in the context of the previous discussion about lung versus X-ray and what do you do about it, that is one of the spicy points, that we constantly rely on our clinical exam, on our suppositions about what we're hearing, looking, feeling, and pretest probability, and we write it down, but it has no value whatsoever in terms of actually what we heard or what we did. I guess I come from a place where we have all our images going to PACS. We have 100% QA, so it's a little bit of a different model. But I think what is most important to me about, I guess, relative to the question about the stethoscope, ultimately, especially in the critical patient, when you're at the bedside trying to make a decision, you're trying to use the best data available at the time to actually make the right clinical decisions. So an X-ray is relatively useless for that. It's not much different than clinical pretest probability in terms of its sensitivity. So whether you later order an X-ray for confirmation for downstream use or not, that's certainly a call. But at the time of managing the patient, I don't think there's much question now in terms of literature that becoming facile with understanding how to look at a set of lungs and then correlate that with cardiac function, IVC or VEXUS, whatever other level of framing you want to do, really changes management. So I guess my advocacy is that, especially when there's a lull in the action with the unnamed COVID epidemic, that the time to get facile at lung ultrasound, understand how its nuances and how to use it is really now. And I would argue strongly that over X-ray, it's the correct test to do. I'll shut up after that dialogue.
So there's another question here from Stephen, one of my colleagues from Beaumont ICU. Anesthesia. He's one of the anesthesia trainees. So he asks, is there data on how long lung ultrasound takes by trainees and any effects on infection control? So I'll just open that to the panel. The guys from ED and anybody from the intensive care stream would like to take that one? Um, no. Difficult question, Stephen. Stephen, can I just clarify that question? When you say how long lung ultrasound takes, do you mean the examination itself, or do you mean how many scans you need to do? I suppose how many scans you need to do before you get good at it, Stephen? Nope.
Was mute. I was wondering in terms of per patient. So let's say you do 10 chest X-rays in the morning. You know, how long is it going to take for trainees to do all of them by lung ultrasound? You know, will it impact on other activities? And then, is there effects on infection control? You know, are people properly disinfecting? You know, as disciplined as radiography might do? That's what I was interested in.
Okay, I suppose I think maybe I'll take that question because I've been using it quite a bit in Beaumont ICU. So what's been happening in Beaumont ICU? So I'll answer the question about the infection control piece first. So if you, you know, in Beaumont, if you're using the ultrasound in the COVID area, the COVID general ICU, once it goes in, you know, and when you bring it out of the COVID ICU, you will the healthcare assistants will actually clean it down to infection control standards. So they will wipe it with the bleach solution. They will dry it. They will put the probes in trophon. So we have a new device from I think it cleans the probes, and then you seal it up after that. You have a marker there to say that it was cleaned properly. So I suppose that is in relation to your infection control question. I think it's also paramount on operators as well to actually clean it down yourself. So if you put in a central line, if you do a lung ultrasound, if you echo someone, I think you should clean it anyway. But the healthcare assistants will certainly do that, and you know, if you just point it out to them, they will certainly do it for you, or show you how to do it. Then the other bit about how long lung ultrasound takes. So I think that question, I suppose it depends on what you're looking for. You know, if you're looking for a pleural fusion, if you're looking for a pneumothorax, then that's a very, very quick study. If you're looking specifically for pneumonia, then it could be a little bit more nuanced, then it could take a little bit more time. I would give myself maybe 10 minutes at most. After that, I start to lose interest. Okay, so so Michael Quirk, Michael is actually on the panel. So he asks, was lung ultrasound used much in Beaumont ICU during COVID-19? And there's a question for Peter as well. Was it used for ED? Was it used in ED for risk stratification?
I suppose what I wanted to say, because I pressed the return button too soon, and I was trying to space out my message. But hi, Peter. Mike Quirk here, ED consultant in Beaumont. Fantastic talk. Nick, really, really informative. And I think the trainees in our ED will be certainly very, very happy for the teaching you gave them. So thank you. I'm going to raise the C word officially. Apologies about that. Peter, in Vermont, I don't know how badly you were hit with COVID-19, but did you find point-of-care ultrasound at the front door? And Keane McDermott is involved in this too. I know probably a lot more than I am. Did you find it helpful? And then just Nick, maybe, or one of the other ICU consultants, if they'd like to just give us a little idea of how you did lung ultrasound in a COVID ICU. Did you find it useful? Did you find it beneficial for assessing response and stratifying, I suppose, severity? Maybe that's what I meant to type, but I didn't do a very good job of it.
Well, I can talk about the ED, how we did it in Vermont. So in my world, it was very useful, although I think in the whole concept of COVID, there was a lot of evolution as to what we were doing with patients in general. So the concept was how we had no testing that was sensitive and we didn't have it available. So you had a lot of patients showing up. We actually had a parking lot set up outside with tents because of the number of patients showing up. And the question was who has the disease and how to risk stratify them. And so there is, there's still more descriptive versus prospective data published about the idea that the lung ultrasound was about as sensitive as a CT scan to pick up peripheral distal findings, which is classically early COVID. And we were picking up patients who were coming in for screening for a fever without respiratory symptoms, and they had early signs by lung ultrasound that they actually had had the disease. The caveat is that what we were doing with these patients, we did not have oxygen monitors to send them home with. The walkie-talkies who hadn't decompensated, we were saying go home and quarantine, and then we were using that to risk stratify patients who just seemed a little bit sicker to come in and get OBS and potentially get admitted for oxygen therapy and high flow nasal cannula, different management strategies. So I'm winding on here. The one thing that was very helpful for me about using a lung ultrasound was we had no PPE. And every time one of my colleagues would order a portable chest x-ray, that meant that 2 radiology techs were actually donning homemade PPE from some of the farmers up north who were sewing it for them. They would don homemade PPE, put on N95s, go into a patient's room, take a substandard view of their lungs, and then walk out, having to clean off the machine, chucking the N95 in the trash, and potentially contaminated, which seemed crazy versus me. We had Butterfly IQs as our COVID devices, which is a tiny device, easy to clean, and it made much more sense as a provider in a pandemic to be able to go into the room anyway with my PPE, ask a better test about whether I was seeing COVID findings or not, and then use that information with my clinical pretest probability to risk stratify the patient and manage them that way. And so that was a really important thing for us to evolve to. Long answer. I'll defer to Kian about his world.
Okay, so let's see next.